So this is going to end up on YouTube as well, isn't it?
Yeah. You're good with that, Katherine, right?
Yeah, it's fine.
I have to apologize because you didn't tell me the last time we were going to put this on YouTube, and I was in my bed in my pajamas, happy.
I didn't notice. You look the same as what I thought you know.
Thank you. Oh, right. That's a little bit offensive. I tried to make an effort today with like a jacket, and then my wife was asking where are you going, and I was like, nowhere. How are you feeling, Katherine?
Yeah, good. Thanks for having me on.
How's your
week
nervous? Been? Yeah, no, that's okay. How's your week been?
Yeah, it's been good. Just been at work getting a couple of Vivas, so slowly getting into it.
Oh, good. Now, you were a bit hesitant to come on, but I just want to explore what made you decide, yeah, I'll give this a go.
I think I sort of decided that it'd be good to put a bit of pressure on myself to step out of my comfort zone and actually give it a bit of a crack with some more pressure on myself rather than just sort of talking through it with my study group and that sort of thing. So it makes it feel a bit more like the real thing.
That's really great. And when I think about it, I feel like pressure is not new to you or, most doctors. First of all, you went for medicine, right? Like year 12, you went for it, you absorbed that pressure and all your exams up to this point. But does it feel a bit, and this is what I felt, that now I've already proven myself. I've got this perception of something to lose. And that's why I feel like I've got this pressure on me, because people think I'm smart and I don't want them to realize that I'm not. That's what I thought.
Yeah, that's probably pretty accurate, I think.
Yeah, okay. But then the trajectory stops as soon as you believe that, I think. And that's what you're doing is really great. It took me, I don't know if I told you this, the first video that I made for YouTube was made in 2012, and it took me until 2020 to actually put it on YouTube. That's how bad I was. So well done. You're far ahead of me.
And look at you now, La. You're a YouTube star.
Yeah.
But I think, Katherine, that's a really good point in terms of that acceptance of, the pressure and what's there to come. And, they talk about action levels and how you're feeling, because at that stage, when you're sort of feeling doubtful, when you're sort of feeling a bit down on yourself, your action level in terms of what you do is low. Whereas when you learn to accept and you become more positive about the opportunities that are out there, your action level increases and you take these opportunities, and that's how you learn, that's how you grow, and that's how you become a better person. So not just for this Viva, but just life in general. I'm too old, as you can tell.
That's
too old. Too.
Stan says that, but his actions don't speak like that at all.
Too philosophical.
Okay, no, that sounds very wise, Stan.
Again, welcome everyone to ABCs of Anaesthesia and the Anaesthesia Coffee Break. So we're going to do a Viva with Katherine. So thanks so much for coming on. We're going to go through the Viva 4 parts, just like the real Viva. But also, I was thinking we might get a performance tip out of you as well, Katherine. Hey, Katherine. So let's start. I know I'm putting you on the spot. Is there something that you did, or you would encourage people to do for your first part study that you consider like a performance tip? I
think you guys have probably said this before, but I think consistency was the biggest thing for me, and also having a good study group. Shout out to them. I have an amazing study group that I'm still studying with at the moment, and we made sure that every week we caught up, and usually it was on a Sunday evening, and we had predefined tasks that we did. I think that kept us all accountable right through the whole process, which I definitely would have been slacked off at times otherwise, but I think that was really important for us.
Oh, that's fantastic.
That's really good. I mean, that's the secret ingredient, isn't it? Have a support, really good support group behind you and keeping you accountable, keeping you consistent. All these are keys to success. So well done, Katherine. Well done.
So let's get started. Stan, did you want to go first with your questions?
Yeah, absolutely. So we'll start the timer.
Yep, I'll do that now. And what will I do? I'll flash it up when maybe 20 seconds to go.
Yeah, flash it up. Yep.
Sounds good. Let's go starting now.
All right. So Katherine, what is ketamine?
Ketamine is an NMDA receptor antagonist that's commonly used for induction of anesthesia, but also for other uses, including postoperative analgesia as a pre-medication.
How is ketamine presented?
Ketamine typically comes in 2 mils with 200 milligrams clear colorless solution, which is typically made up into a 20 ml solution, making 10 milligrams per mil. It's quite acidic with a pH of about 4, and the ketamine itself is a weak base with a pKa of 7.5. That's why it can be water soluble.
Excellent. Does it contain any preservatives?
It does contain preservatives. I think it's benzothonium chloride, which means that it can't be used for neuraxial use.
And with the ketamine itself, are there any sort of special properties about what's in it?
Probably, but I'm not quite sure what you mean by that question.
So they say that ketamine is a race mixture. What do they mean by that?
So ketamine is a racemic mixture, is a mixture of equal amounts of 2 enantiomers. So ketamine has an R and S enantiomer. And in Australia, it comes in the racemic mixture of R and S. You can actually get pure S enantiomer mixture overseas, but it's not available in Australia.
Okay. And what do you mean by enantiomer?
So enantiomer is a type of stereoisomer that has a chiral center. So you have 2 different molecules that have the same molecular arrangement, but they're essentially opposites of each other, so they can't be superimposed. And
you said chiral center. What's a chiral center?
A chiral center in anesthesia is usually a carbon or a quaternary nitrogen atom, which has 4 different groups surrounding it. And the arrangement of those groups determines whether it's R or S. So that refers to the increasing number of the molecular weight of those atoms surrounding the structure.
Now, you mentioned that ketamine is an NMDA antagonist. Explain to me how else it works.
So aside from being an NMDA receptor antagonist, ketamine actually has a number of other receptors that it works on, which can be associated with some of its side effects. So these include the muscarinic and nicotinic acetylcholine receptors. It's a weak mu opioid antagonist, but a kappa and delta agonist. And I think there's possibly another receptor that it works on too.
Okay.
I can't remember.
And then tell me how it works on the NMDA receptor.
So it's a non-competitive antagonist. It binds to the phencyclidine binding site and prevents opening of the NMDA receptor, therefore reducing excitatory transmission throughout the CNS.
And what do you mean by non-competitive antagonists?
So a non-competitive antagonist binds to a different site to the allosteric site, which is where the natural ligand binds. So it doesn't work at the same site.
Okay. Now, you mentioned that ketamine has multiple uses, and one of them was analgesia. How does it produce its analgesic effects?
Analgesic effects are predominantly through antagonism of the NMDA receptor in the dorsal horn of the spinal cord, so preventing ascending transmission. And it also has roles in preventing opioid tolerance and in even reversing opioid tolerance.
Now, you mentioned that ketamine has some opioid receptor activity. If I use naloxone, does it have any effect on ketamine?
I don't believe so.
Okay. What are the side effects of ketamine?
Ketamine has many side effects. If we break it down by system, the central nervous system side effects include agitation, delirium, hallucinations, an increase in CMRO2, and therefore cerebral blood flow and intracranial pressure. Cardiovascular wise, it's a direct myocardial depressant, but usually the sympathetic stimulation effects outweigh that and you get a tachycardia and hypertension. In the respiratory system, it's a bronchodilator, or rather the R enantiomer is, and there's some evidence that it can increase pulmonary vascular resistance, and it can also significantly increase secretions, lacrimation as well. And in terms of GIT, it does cause nausea and vomiting.
Okay. And what's the mechanism of emergence delirium in with ketamine?
So some of that's thought to be through the antagonism of muscarinic receptors and nicotinic receptors in the CNS.
Okay. Now, what does intracranial pressure mean to you?
Intracranial pressure is the pressure exerted within the cranial vault.
And what's its normal value?
Normal value is 5 to 15 millimeters of mercury.
Why is it important we know what intracranial pressure is?
Intracranial pressure needs to be very tightly regulated because if it above that area, you can end up with areas of focal and then global ischemia. So at 20 millimeters of mercury, you get focal ischemia, and global above 50 millimeters of mercury.
Okay. And what's the mechanism of how intracranial pressure causes focal ischemia?
So the determinants of intracranial pressure can be described by the Monroe-Kelly doctrine. So an increase in either brain, CSF, or blood can increase intracranial pressure. Usually those things are buffered up to a point when buffering is exhausted, and then intracranial pressure will rise. And depending on where those, like for example, if there's a tumor, then you can cause focal ischemia nearby that.
And when you talk about focal ischemia, like why is there a reduction in delivery of oxygen to those cells?
So you end up with reduction. So the blood vessels essentially are compressed, and so oxygen isn't able to get there. Okay.
Now, you mentioned about the Monroe-Kelly doctrine and its components. How much does each approximately contribute?
Parenchyma tends to be 85, usually is 85%, CSF is 10%, and blood is 5%.
And you said there was compensation up to a point. Like what's this compensation?
So the first thing that happens is CSF is displaced from the cranium down into the spinal cord or spinal canal. That contributes most of the buffering, although it is a bit slower. Additionally, you can have venous buffering, which can be, so blood can be moved from the valvulus venous sinuses down into the rest of the body, and to reduce the pressure. And that is quick, but it doesn't have much capacity.
Now, what's the relationship between cerebral blood flow and cerebral blood volume? So if I was to increase cerebral blood flow, does it automatically mean I'm increasing cerebral blood volume?
No, it doesn't. So normally cerebral blood flow is autoregulated over a range of 50 to 150 millimeters of mercury, meaning that flow is constant over that perfusion pressure.
Okay. And then what are the factors that affect cerebral blood flow?
Cerebral blood flow factors determining it can be described by Ohm's law. So in terms of your perfusion pressure, it's MAP minus your mean arterial pressure minus your intracranial pressure divided by your cerebrovascular resistance. In terms of cerebrovascular resistance, the most important determinant, as described by Purcell's equation, is radius. And things that change the radius include CO2, oxygen, acidosis, and the local metabolic demand of the tissue. So with increased CO2, you get vasodilation, and same with decreased O2 and a lower pH.
Okay. So let's say above the autoregulation range where cerebral blood flow starts increasing, what magnitude of change would it have on cerebral blood volume?
I think it can increase quite significantly at that stage. I can't actually quantify it though for you, sorry.
Okay. How do volatiles affect cerebral blood flow?
Volatiles have a dose-dependent response on cerebral blood flow through uncoupling of the relationship between CMRO2 and cerebral blood flow. Depending on where you read, at low volumes, it can actually decrease your cerebral blood flow due to the reduction in CMRO2. At about 1 MAC, it's thought that the relationship is about the same, so you end up with no change compared to baseline.
And when you say that there's no change, what's the other competing force to?
So you have decreased CMRO2, but increased cerebral blood flow relative to that reduction in CMRO2.
Yeah, and why would there be an increase in blood flow despite a decrease metabolic consumption?
Just because they cause vasodilation.
Yeah. Good.
Okay, let's move on. What is anaphylaxis, Katherine?
Anaphylaxis is a severe systemic IgE-mediated type 1 allergic reaction.
And tell me about the IgE.
So IgE is produced from an initial exposure. So upon initial exposure, an antigen-presenting cell presents the antigen or allergen to T helper cells, which activate B cells to produce IgE. IgE then coats mast cells in the tissues and basophils in the circulation. And upon subsequent exposure, that IgE is cross-linked by the allergen, causing degranulation.
What mediators are released on degranulation?
There's initial mediators and then late mediators. The initial mediators are predominantly histamine and tryptase and a small amount of serotonin. Late mediators are synthesized and include prostaglandins, leukotriene, and bradykinin, and cytokines.
And what does that cause?
So it causes for histamine is responsible for most of the immediate effects. It causes quite profound capillary leakage, vasodilation, but it also causes tachycardia and increased chronotropy.
And what does the capillary leakiness cause?
So it causes like loss of fluid into the interstitium, and you can get edema. You also get decreased systemic vascular resistance, hypotension.
Sounds good. Any other effects?
So it's got effects, can have effects on the respiratory system. So histamine causes, and particularly leukotrienes as well, cause bronchoconstriction. So you can have bronchospasm, high airway pressures if you're under anesthesia. There's also gastrointestinal effects. So nausea, vomiting, diarrhea, and cutaneous signs such as the wheal and flare response. And it can also have derangements on coagulation, cause DIC.
What happens in DIC?
So you have a consumptive coagulopathy. There's consumption of rapid clotting as well as breakdown of clots, and you get consumption of your coagulation factors and fibrinogen.
And how would you treat anaphylaxis?
The main treatment for anaphylaxis is adrenaline alongside supportive treatment. So adrenaline is a adrenergic receptor agonist. It works at alpha-1, beta-1, and beta-2 receptors. Its predominant effect in anaphylaxis is through the beta-2 effect of mast cell stabilization to prevent further degranulation and histamine release.
Any other effects of adrenaline?
So its effects on the alpha-1 receptor are more predominant at high doses and is vasoconstriction, increasing systemic vascular resistance and blood pressure. And on the beta-1 receptors causes increased heart rate, increased inotropy and chronotropy, and increased contractility.
Any other beneficial effects of adrenaline?
On the respiratory system, the beta-2 effects also causes bronchodilation, which is very helpful.
What are the supportive treatments?
So supportive treatments, we can go through our A to E approach. So in terms of, you want to make sure that the airway is managed. So it might require intubation, ventilation. You can, in terms of breathing, you can use beta-2 agonists to help with bronchospasm if it's not improved by the adrenaline. You can give adrenaline nebs as well. Sometimes, so in terms of circulation, you can use fluid boluses, and sometimes steroids are used as well.
How much fluid is required? Or how much fluid is
sometimes so it can be quite significant through the capillary leakage. I think, I don't actually know an exact number, but perhaps 500 mils to a litre potentially could be lost.
How does adrenaline prevent mast cell histamine release?
So it's through an action on beta-2 receptors. So they're DSG coupled protein receptors. Which
what is an anaphylactoid reaction, and how does it differ?
An anaphylactoid reaction has a very similar clinical picture to an anaphylactic reaction, except it's non-IgE mediated degranulation of mast cells.
And is it severe, less severe?
It can be just as severe. So clinically, you would probably just treat it as anaphylaxis.
How would you differentiate between anaphylactoid or anaphylaxis?
It's mostly due to testing with tryptases later on. So while anaphylactoid reactions do still have mast cell degranulation and tryptase release, it's to a lesser extent than in the anaphylactic reaction.
Are there any other cells involved in anaphylaxis?
So apart from the mast cells, there's also the basophils in the circulation. And then later on, there's activation of the complement cascade and also of the cytokines cause chemotaxis and activation of other white cells.
Okay, good. Let's change topic. What is in a bag of normal saline?
Normal saline contains 154 millimoles per litre of sodium and 154 millimoles per litre of chloride. So it's essentially 9 grams of sodium chloride in 1 litre of sterile water.
What's normal about normal saline?
Not much. There's not much physiological about normal saline. The only thing that is perhaps physiological is its osmolality, which is 285 milliosmoles per litre as the non-ideal, although its ideal osmolality is 308 milliosmoles per litre. So it is isotonic, isoosmolar, I should say.
What is the difference between osmolarity and osmolality?
So osmolality is the number of osmoles per kilogram of solution, and osmolarity with an R is the number of osmoles per litre of solution.
So what's this difference?
So normally there shouldn't really be any difference because usually 1 litre equals 1 kilo, but in certain situations where it doesn't, then they can be different.
And sorry, what would make those two values different?
So, for example, if you had increased temperature, then the 1 litre would essentially swell in volume because the molecules move further apart, and then it wouldn't be the same.
And how do you measure osmolality?
So osmolality is measured with an osmometer, and that uses the fact that 1 osmol will depress the freezing point of a substance by 1.86 Kelvin.
And how is osmolarity calculated?
Osmolarity is calculated from using it's a calculation of 2 times the sodium concentration plus glucose plus urea. So of those osmotically active substances in the plasma.
Mm-hmm. Okay. What are colligative properties?
Colligative properties are properties of a solution that are entirely based on its osmolality or osmolarity and not the particles themselves.
Mm-hmm. And what are those?
So they include depression of the vapor pressure, depression of freezing point, elevation of boiling point, and osmotic pressure.
Mm-hmm. What does antifreeze do?
Antifreeze is essentially adding osmoles to a solution. So it depresses the freezing point of a solution.
Mm-hmm. And how does that work?
It works by the same way that osmoles depress freezing point. I guess it's kind of like adding salt to a road in winter, and it prevents freezing by reducing the freezing point of the water on the road.
So what is the similarity with antifreeze then?
I guess it's probably the same property in that it's just depressing the freezing point of osmoles.
What is it about the antifreeze that depresses it?
That it has a large number of osmoles.
Sounds good.
Sorry, I'm probably
that's exactly
barking up the wrong tree.
Tell me about anion gap.
So the anion gap is the difference. Sorry, I'm just like stuck in colligative properties. The anion gap is the difference between the measured cations and the measured anions in solution. So it's sodium plus potassium minus bicarb minus chloride.
And when you have a wide anion gap, what does that mean?
So a high anion gap means that there's the presence of unmeasured anions in solution. Typically, these are things that can cause like a high anion gap metabolic acidosis. So includes lactate, ketones, toxins, and renal failure.
Mm-hmm. What happens if you give too much normal saline?
if you give too much normal saline, you can end up with a normal anion gap metabolic acidosis, which is due to hyperchloremia.
Excellent. And that's time. Well done.
Well done.
That's so good.
Thanks, that was hard.
That was challenging.
Do you feel all right?
Yeah, I was a bit rattled by the antifreeze.
I may have just asked the same question again. I'm so sorry. But yeah, it was increased number of particles. So first of all, from me, yeah, you present really well. You speak really well. You know, to the point, the strategy of the way you're answering the question, you know, to the point. Then with a pause, you know, allows me to kind of further ask more questions. Yeah, and you know, you knew a lot of detail about that stuff. So yeah, absolutely fantastic. Well done.
Thanks.
No, and I think that's a really important point you make, Lara, because with a lot of candidates, they do answer questions and they go on. And I think it's a really good thing that you've got in terms of you answer the question succinctly and actually allow the examiner or us to actually ask you questions. So you actually engage us. And there is a human element to this exam. So you want to engage the examiner, you want them to be involved, and you did that. So it was a very, I enjoyed the Viva. Did you enjoy the Viva?
Yeah, it was good. Thank you.
Well, hey, La, you know, we were meant to give I promised Katherine would give her core topics, and you an antifreeze, hey?
Yeah, I mean, I didn't get the memo. You didn't tell me.
Even I'd be lost for words.
I've got to say, the whole core topics thing, I don't think anyone gets asked a core topic. You know, I think I got one core topic.
Oh, did you?
Everything else just felt
you're doing so well. Doing so well.
Anyway, go on.
No. So look, we'll go through what you talked about, but just before then, you know, just sort of give us your thoughts on how you felt the Viva went.
I think overall, I felt a bit scattered at some times and felt like my thoughts weren't quite flowing very well. But I think I've been working on trying to pause in between and make sure that the examiner does have time to ask me questions. And I think that helped this time around in terms of actually directing the flow of the Viva. So in that sense, I felt better than previous ones that I've done.
Yeah. And this is only your second week. So it's been, the trajectory is on the right path. Like you'll be ready for the exam next week, I reckon, at this rate.
That's a scary thought, Stan.
The sooner you get it done, the sooner you're free into lockdown like the rest of us. But
yeah.
That's right. So look, with the ketamine question, really good, strong introduction, especially with an open question like ketamine or what is ketamine. You had a good description of how it worked as well as its uses. And I think that's a very good sort of strategy to have with definitions for any drug. So well done on that. You were very knowledgeable to know that ketamine does have a preservative, and you actually named it correctly, benzethonium. Now, here's a little trick for you. I mean, here's a little tidbit for you. So yes, ketamine does have a preservative, but there are ampules of ketamine out there which do not have preservatives. So those are made by Baxter, and you'll see those preservative free. Okay, but the preservative, you'll see that the ones that we have in our hospitals commonly do have that preservative there. Okay. Your description of the RNS ketamine was spot on, and
I've got a bone to pick just with that.
Sorry, what was that? Sorry,
you're both saying racemic, like racemic. And
sorry.
Is this some kind of racial thing?
Racemic, yeah. Apologies.
Racemic. Come on, guys.
I think Katherine just followed on from my mispronunciation of racemic. So apologies.
And I'm glad that you did mispronunciation instead of mispronunciation. So that was really good. Oh, I'm the police now. I'm so sorry.
Now that our viewers can actually see us live on YouTube, they'll know that we are ethnic. So we are allowed to mispronounce certain words.
Yep.
And they'll have to forgive us for that. Okay. So with regards to enantiomers, good description. I think your description of the RNS was correct. It's to do with the configuration of the 4 functional groups around the chiral center. Do you know what the other the other types of enantiomer is?
So it can be also determined by the way it rotates the plane of polarized light.
Beautiful. Yeah. And then what's the naming of that?
So that's an optical isomer.
Yeah. And then do you know
Optical
the two?
stereoisomer.
Yeah. Like, do you know the twos that like how they name whether it goes left or right?
So I think levo, there's levo and dextro rotatory.
Yes.
And I can't remember if levo's left or not.
Yeah,
I feel
levo's
like
left.
it is cool. I was
yeah,
like, is the
right.
L a red herring?
Now, good. And then with the other things of ketamine, yes, it does work. It does have weak activity on the opioid receptors, but it's so weak that naloxone doesn't have an effect on it. Now, the interesting thing is with your, can I just say, very good description of the NMDA receptor and its non-competitive binding. I thought you had a really good grasp of the concept of what a non-competitive antagonist is versus a competitive antagonist. So you described a non-competitive antagonist very, very well, okay, with its different binding site to the allosteric binding site of the actual ligand, which is glutamate. Now, when we talk about ketamine and its analgesic effects, so a lot of people talk about the NMDA receptor, but know that the NMDA receptor is implicated in things like hyperalgesia and neuropathic pain. And the reason for that is that the NMDA receptor is implicated in memory, memory learning. And that's why you tend to sort of use it to reduce that. Now, the way that ketamine is thought to have analgesic effects, and it's quite complicated, and I don't think anyone sort of understands it, but you see, I think the best summary comes from Stolting, and I think Hemmings also mentions it as well. So they talk about activation of the descending inhibitory monoaminergic pathways, so adrenaline and serotonin. Then they also talk about its similarity to local anesthetics, where it blocks sodium channels. And then the third one, which is a little bit controversial, and this is where it gets quite contradictory with ketamine's effect, is have you seen that neuronal nicotinic acetylcholine receptors? So it's got apparently antagonistic effects on those nicotinic receptors, but we know that a lot of nicotine's side effects, which you described correctly, are cholinergic effects, which means that they have agonist effects at the muscarinic receptors. So this is why it's very confusing. But because of that interesting differing point, that's how I sort of remember it.
It's interesting.
Thanks, Dan. That's good.
It's been a while since I studied ketamine and its actions, but it worked on like every receptor except GABA. Is that right?
Yeah. Yep.
Pretty much.
Right. Yeah. So it doesn't work on the same receptor as propofol and midazolam. Yep. And then the way that it causes emergence delirium is thought to be due to the way that it interacts with the NMDA receptors at the brainstem level. So what it does is, I think there's a couple of auditory nucleuses which it blocks, and so what happens is that and it's probably some visual nucleuses as well, and so that visual auditory sensation that you get gets misinterpreted by the brain, and that's how they get crazy dreams. So but that's all like little minutiae, because otherwise, the core of that ketamine Viva was very, very strong. And the only reason why I sort of pushed you on those sort of questions was because of how well you answered and how well you structured those really core questions. All right. With regards to the ICP Viva stem, again, very, very strong. So you had a very good grasp of the Monroe-Kelly doctrine and the way that the intracranial pressure affects cerebral blood flow. This was where I also pushed you as well, because there is I think a little bit of confusion between cerebral blood flow versus cerebral blood volume. Like, is it a one-to-one effect? And I think the graph that the line is from, the reference is actually from Miller's, where I believe it's for every 50% increase, 40 to 50% increase in cerebral blood flow is about a 20% increase in cerebral blood volume. All right, let me just make sure I get that right. So yeah, so a 50% increase in cerebral blood flow results in a change in cerebral blood volume of only 20%. All right, so not exactly one-to-one. But your description of the factors were really good. So you talked about the myogenic autoregulation from arterial blood pressure, the metabolic flow metabolism coupling, and PaCO2, PaO2. Very, very good. And then, with regards to how volatiles affect cerebral blood flow, yeah, you got it. It's the interplay between flow metabolism coupling versus the direct vasodilatory effects. Very good. Very, very strong, Katherine. Very, very strong. Good. So well done.
Thanks, Dan.
Similarly with my question. So first one was Anaphylaxis. And so I won't go through all of it because I think you just answered it really well. So anyone who wants to listen can listen to your answers, and pretty much that's exactly the way we wanted this Viva to go. I think interestingly, when people think of mediators, you mentioned a lot of mediators, and people often will forget tryptase because that's not in the context of of the bad effects of tryptase. It's just the thing you measure, and that can often get forgotten. So that was really great that you mentioned that. And then, to always mention the cardiovascular, respiratory, and maybe inflammatory and other gastrointestinal effects in one go, because these are broadly speaking all the systemic effects that could occur. You also volunteered the clotting effect. So the fact that it can cause DIC. So that was fantastic because a lot of people don't think about that. And I rarely think about that in an acute anaphylaxis setting because it really isn't something I think about acutely because you don't observe it, but it can definitely happen. Going through the adrenaline effects, yeah, it just has all those effects, and we got around to talking about all of them, including cardiovascular and respiratory effects. Cardiovascular being increased chronotropy, inotropy, stopping mast cell degranulation, as well as vasoconstriction to increase central blood volume, and then bronchodilation for the respiratory effects. And then good anaphylactoid versus anaphylactic, fantastic. And that was pretty much the whole Viva. So again, very strong. You went through very quickly. Your answers were succinct and to the point. So I was really happy with that. Now this was a bit of a left to center Viva about bag of normal saline. And I feel like a lot of the times you get thrown off is not just because the question is a bit different, but because you use a bag of saline or CSL, or you watch your monitors every day, and do you ever really look at the pressure waveform or the volume or the flow wave? And those are the things that often throw me. So, as a tip to everyone doing this exam, think about what you're, looking at in your own environment, and think, what don't I know about the bear hugger, or what don't I know about the thermistor because I'm putting it in every day? So yeah, and so you're very correct about the concentrations, the fact that it really isn't very normal, the fact that, and you're giving me really good definitions for osmolarity and osmolality.
Those were super strong definitions.
That's right.
Like I think a lot of people do struggle with those simple things like definitions because there's so many of them, but they came out strong and succinct. So it was really impressive.
Someone said once that there's too many L's in osmolality, so it can't be the liters.
Oh yeah. That's a good one.
That's a good one. Oh, everyone, there's the mnemonic right there.
Yes.
I reckon when I first started studying this, I thought, is that just a typo? Because I'd never heard of osmolality before. Anyway, so osmolarity is kilos, but like you said, there's too many L's already. What's the difference? And yeah, so one generally the same, but if temperature increases, then osmolarity will be less. So it's due to the presence of osmotically active particles. And you mentioned how an osmometer works, which is freezing point depression, which is fantastic. And osmolarity is far easier to measure because you just do a bit of addition of sodium, glucose, and urea. That is 2 times sodium, glucose, and urea. And then we even got into colligative properties, really fun word to say. And you mentioned the different points, so boiling point, saturated pressure changes, freezing point depression, and osmosis as well. And then we talked straight from there into antifreeze and just look. Actually, this was a good example of I'm looking like sometimes your examiner won't be that familiar with the Viva, or they'll be trying to do two things at once and they're reading something, maybe the next question, and they're distracted. I was definitely distracted. And so you may have answered that question, and I probably just asked the same question that you'd answered. So just be aware of that, you know, maybe you might see a bit of a glazed look from your examiner, maybe they look down at the page. Appreciate that and think that maybe I just need to say the same answer again. And I'm not actually not sure, but potentially you'd already said that it's because of the number of increased number of particles. And then, yeah, so take home point, maybe you said the answer, think about that, think about managing the exam. And if you're saying a really important point, look them in the eye and go, what I really care about is this, or this is the most important thing about this situation. And then finally,
I've been hanging out. What is the answer for antifreeze? So that
as in increased number of particles.
That's exactly what you said, Katherine. Exactly. About honestly, I think you said it about 3 times.
I was totally distracted. I'm so sorry.
I thought I was backing up the wrong tree.
I don't know where my head was reading about. I was reading about metabolic acidosis and thinking about strong iron difference, and completely distracted.
Front running.
All right, and then you went into the salient causes of it, and also that increased normal saline administration will give you a normal anion gap metabolic acidosis that is hyperchloremic as well. Excellent, very well done. So happy with the way you answered those questions there. Yeah, congrats.
And
thanks so much, Lawrence, Dan.
And you know, the thing is, each time we do this with sort of someone here, I can tell you our Vivas are getting harder and harder and harder. So for all those that don't know, all that Katherine had was just the first couple of questions. That's it. Whereas previously we've always given candidates our whole stem. So a lot of it, especially with the definitions, she had to know it herself. So very, very impressed. Good work, Katherine.
Thank you.
Okay.
Hey, what are you gonna do? Yeah, what are you gonna do when you finish the exam? What are your plans?
If we're not in lockdown, which I suspect we will be, hopefully I get to go back to Tassie to visit my family. That'd be nice.
Oh, you'll be nice, Tassie. Yeah. Well, hopefully I'm only go to Tassie too in Jan. We'll be okay by then, right?
Yeah.
I hope so.
You just swim there, you know, just start at St. Kilda Beach and just keep going south.
I'm sure it's been done.
Yeah, that's right. And so thank you, everyone. Especially thanks, Katherine, for joining us and, you know, pretty much getting examined and grilled live on our podcast. And hope everyone gets a lot out of this. And yeah, we'll see you next time. Thanks for listening to another episode of Anaesthesia Coffee Break. See you guys next time.
Thanks so much, guys. Have a lovely rest of your evening. Thanks for
no
having me
problem
again.
at all.